Our roundtable discussion today will focus on translating evidence to inform policies and practices on improving adolescent, youth health and nutrition. And we have learned from the sessions earlier today, we've seen a lot of good work that is done in terms of generating evidence, but what's the use of having good science if we cannot change policy? And what's the use of having policies if we cannot change life? I think this is that transitioning from evidence to policies to practice. What does it take? So we have an excellent panel this afternoon. Myself, my name is Ramadhani Noor. I'm with UNICEF Ethiopia Country Office. And I have a pleasure today to co-moderate the session with excellent colleague, Dr. Hannah Gulema from Addis Continental Institute of Public Health. And I will request Gulema to introduce the panel.
Thank you, Dr. Noor, for the introduction. I will introduce the panelists from right to left. So we have for the nutrition, Dr. Masresha Tasama. Dr. Masresha is working at EPHI, and he's a senior researcher and director of Food and Nutrition Research Directorate. Again, we have Adam Osai. She's expert on mental health, and she's from Child Rights Lawyer and founder executive director of Mentoring Assistant for Youth Initiative in Nigeria. Again, we have Mariam Awit. She's representing youth and adolescent here. So she's youth advocate, youth innovation champion at PSI Ethiopia. And we have Dr. Emefa Modai is from Ghana and is a lecturer at the University of Ghana School of Public Health, and she is expert in SRH. Thank you. I will leave the floor for Dr. Noor. Thank you.
Thank you very much. May I just request just a round of applause to the panel for being here. So we'll get straight, and just to highlight a few things, when we started to pay attention to a lot of what is happening with adolescents, there was an interesting report. We used to call it AHA report. And early this year, I think a second guidance on AHA report came out. That's an effort by WHO, UNICEF, and other agencies. And that report helps to the AHA really stands to Accelerated Actions for Health of Adolescent. So it's a guidance, and the main use for that report is really to provide reference for countries in seeking to improve health and well-being of the adolescent populations. In this second guidance, I think we have seen much of what has been presented and discussed earlier today. Adolescents are growing in a significant proportion of our population. They still continue to bear a substantial proportion of the global disease burden. I think what's also striking to see is that what we have achieved in terms of recent very rapid declines in mortality among infants and young children have not translated or mirrored among adolescents. And I think this is why it makes this area increasingly important for us to focus on. So I will not say much, but for this ARISE network, we are focusing on three very important pillars, the nutrition, SRH, and mental health. So maybe just to get straight to my first question, to Dr. Masresha, Dr. Emefa, as well as my sister Dorothy Osei, could you give us at least very briefly the state of adolescent nutrition, sexual reproductive health, as well as the mental health on your own domain? And if you could highlight a bit of what's happening on the policy environment and the practices or programs in your respective countries or the region. Let's start with Dr. Masresha.
Good afternoon, everyone. It's great to be here, and thank you for organizer inviting me. My name is Masresha, as well introduced with my colleagues and best friend, Dr. Ramadhani. So I will just briefly highlight the situation or the current adolescent nutrition status in Ethiopia So mostly from the recent national survey, which is the first in kind, which represent both national and subnational level. So just before going to that figure, I think it's also good to understood, of course, some has already been said during the opening by Her Excellency Minister and other speaker. In Ethiopia, adolescents represent nearly 38%, which is meaning over 38 million adolescents. I think this would, in absolute number, which is much higher than many of our neighboring countries, including Kenya, Uganda, Tanzania. So meaning that we have a greater population of adolescents, which we need to focus, meaning it's almost equal to many our neighboring countries. So having said this, I think there are several evidence already at the global level. Some are very strong evidence. If we work on adolescent, there is likely which we can bring positive change in the next life of as motherhood. So as said also, I think the globe is largely biased on under 5 children and also women of reproductive age. And I also believe that adolescent is somehow it is forgotten. And given I think this project and I think this kind of initiative will create some synergy in terms of focusing adolescent in country. So having said this, in Ethiopia, the adolescent, based on the recent finding, adolescent has several problems. I can say it could be triple burden of the problem. We have large number of adolescents, especially including the girls, as micronutrient deficiency, based on the finding which I presented yesterday also. More than almost 50%, meaning from 2 adolescents, almost 1 adolescent has certain form of micronutrient deficiency. For example, folate is one of the most prevalent micronutrient deficiency, which also, when the adolescent shifted to the motherhood, it will lead to birth defect, which is the neural tube defect, which is also currently increasing from time to time in many parts of Ethiopia. And we have also found that despite Ethiopia has been said 13 months of sunshine, vitamin D deficiency is also increasing, and unfortunately even in Addis also over half of the women has also low vitamin A status in their blood level. While the micronutrient deficiency is reported in this, and we have also a growing problem of overweight, and we have seen that overweight was below 2% in the past decade from small setting. Now, in our recent study, we have found that it's almost over 6% of Ethiopian adolescents in some region, for example, in urban, including the big city, overweight, obesity is getting nearly 20%. This figure obviously has to grow to bigger numbers. And apart from this, and we have also found that substantial number of adolescents as teen or underweight, as well as they have also to somehow stunted, because and this stunting may come from their childhood. So when we see those children who are underweight or overweight, when we combine nearly from 4 adolescents, almost 1 adolescent has whether stunted, underweight or obese. So this is striking, and we need to focus. I think this outcome variable which I'm mentioning is because of various intervention which we didn't able to undertake. For example, there are evidence-based intervention. For example, the IFA supplementation has been proven, but when you see the coverage is still low, it's almost only 10% based on our finding. Of course, in some of the program where UNICEF shown yesterday, there has been substantial increment. And of course, including deworming, health education or nutrition literacy is also very low, which is below 20% or about 10%. These are the main problem which we need to work in terms of adolescent. So having said this, I think working in adolescent would have substantial benefits in terms of gaining for future generation. And some of the behavior, maybe my colleagues on other component will cover. The mental health is also one of the problems. Some of the social behavior that we, bring positive change in adolescents may sustain on their adulthood as well as to their lifetimes. And I do also believe that adolescent has also an important, roles in peace, especially the youth. If we engage them, if they are brought into the positive, they might have substantial contribution to the African peace and security as well. Thank you. Over to you.
Thank you very much, Dr. Masrasha. Dr. Torotho-Osai, how do countries respond in the space of mental health?
Thank you very much, Dr. Noor, and a very good afternoon to all our members of the audience. I will sort of give a brief, background of Nigeria's policy history with respect to mental health. It's been a very long and arduous journey for mental health, and very specifically adolescent mental health in Nigeria. We began with the Lunacy Act, and that has largely shaped even sociocultural perceptions and attitudes to mental health issues. It has tended to be viewed as lunacy. We had our first mental health, policy in 1991. But that made no mention of adolescent mental health. And so issues of adolescent, mental health requirements were neglected, omitted, buried at best. And at some point in, 1995, we then had an adolescent, national health policy. But when you looked at the provisions of that document, it didn't talk about mental health. The best it did was, refer to drug abuse and sort of make provisions for the prevention of drug abuse. We had a milestone in 2007 when we had, a very reform-oriented Minister of Health who, signed a national health policy for adolescents and youth in 2007 that articulated more clearly issues of mental health and, made provisions around how to prevent, how to, all of these things were captured. We then made more significant progress again in 2019 because by that time, a lot more advocacy was coming in and we had more alignment with WHO definitions. We also introduced at that point in time a multi-sectoral agenda to how we view, which is why, actors like myself, who are justice sector actors, I'm a lawyer, began to see space to function in these domains. So by 2019, the country by that time had articulated for itself a national, health policy for adolescents and youth that covered issues of mental health. But while we have this, document, it's not perfect, but it's a significant milestone document. We have a lot of challenges, challenges with respect to funding, for instance. So yes, we know that the document sort of, underpinning it are the values of promoting mental health, preventing, talking about these kinds of things, but there's not enough allocation, to services, to facilities, to even research, which is why, Professor Ayo and this community are doing the best they can to innovate around these challenges. We also have, Nigeria is witnessing a shortage of mental health experts. If it weren't so tragic, it would be laughable to see the ratios we are experiencing with respect to certified psychiatrists and, the existing population. And then when you talk about the adolescent, he or she is largely dependent on family structures and social protection systems. Do they have the ability to walk to these facilities? Are these facilities readily available? So there's talk in the country of integrating, mental health care and services with primary health care and extending that even to rural, locations. I think in recent times, if I were to quickly summarize, one of the gains behind the challenges is the fact that there's more awareness happening. There's an attempt to shift social perceptions away from the typical stigma of, mental health issues, the person is mad or is a lunatic, to broadening the understanding of it, to it's an illness that requires treatment and care. even for us in legal practice, I was sharing with some colleagues, I said, when it comes to substance use, for instance, we have, it just invokes a moral judgment, for us as lawyers, even though, you begin to minimize because you're dealing with adolescents who fall into the juvenile bracket for us. But it's still, it invokes a punitive rather than a corrective or rehabilitative reaction. But when you begin to look at substance use as a disorder, it's paradigm shifting. Then you recognize that, this person needs some psychosocial, some, medical, psychiatric referral process or help. And the thing now is to work, with the school systems and, all, because mental health is so ecosystemic that, the agenda has to be, how do we, coordinate all the multi-sectors that are tied to this, objective of ensuring that our young people thrive and become national assets. How do we coordinate that? So let me stop here.
Thank you very much. Dr. Emefa, the sexual reproductive health agenda has been a priority for some time. How has the policy environment and the programs evolved at country level?
Good afternoon, and thank you all for being here. With regards to the question, thank you, Dr. No and Dr. Hannah. So for Ghana, the state of adolescents is improving, but is not improving at as fast a rate as we would like it to be. For instance, with nutrition, just to tap on a little bit, we have thinness present more in adolescent boys than in females. And with anemia, you have anemia more present in adolescent females than in males. So while there are some improvements, there are still a lot of challenges going on. With mental health, suicide attempts and self-harm is about 20 to 25% in our young adolescents in junior high school, thanks to the school database policy that we've been able to assess. For SRH specifically, we've had very marginal gains in trying to bring down rates of teen pregnancy, which is about 15% of adolescents, and 11% of these pregnancies actually end up in a live birth. So it alludes to the fact that there's 4% of pregnancies that are ending up in unsafe abortions and the complications that ripple on from these. For the condom use and STI infections, similarly, we're having thank you. We're having very marginal gains again. But for the policy in response to some of these challenges that we are having, I would say that Ghana has one of the richest and friendliest policy environments. We have so many policies. We did the policy mapping, over 40 policies that are periodically reviewed. And as Edem said, with the awareness, some of the reviews touch on issues that have become more pressing in response to the current needs, current trends that we are observing. So while we are trying to have all these policies in place to support adolescents, and there's intersectoral collaboration, there are policies that engage with the Ministry of Youth and Sports, with the Ministry of Agric to try and promote healthy lifestyles across all sectors. Because that awareness, again, is coming up where you cannot do this in isolation. You need all those multi-sectoral collaborations to occur. So we have that happening in Ghana, and it translates into a number of good programs that we've introduced. We have clinic services that are now tailored to suit the different age groups. The opening hours are a little more convenient for the adolescents. Unfortunately, with the lots of policies and programs that have been introduced, there are challenges. There are implementation challenges. It would be unfair to assume that the presence of the policy translates into the progress that you're expected to see. So we have these implementation challenges that touch on financial issues, as she's mentioned. Some are human resource issues. Some are lack of coordination and poor communication in terms of the operationalization of what the program is supposed to be achieving. So those are some of the issues that have to be contended with. But fortunately, we do very periodic reviews, and that picks up a number of issues that are coming up. So in terms of the policy environment in Ghana, that's where we are. Thank you.
Thank you, Dr. Emepa. To Mariamawit. So you represent adolescents who are in Ethiopia, but also from the region. I'll be interested to hear from you. How do you relate from what you've heard from the three panel members in terms of efforts around evidence, around policy, around programming? And what's your comment in terms of involvement of adolescent and youth in particular along those efforts? Thank you.
So I'd like to start by saying thank you for choosing me to represent the youth and adolescent community. It's really good to be heard, and I'm glad to be here representing them. Firstly, I would like to say from my experience and from what I have noticed, that there is a slight gap between the actual policy and what's really on the ground. From also what I heard from our panelists, specifically regarding the knowledge on nutrition, SRH, and as well as mental health. So I'll be talking about nutrition, SRH and mental health in universities, because I'm also a university student, and I'll be just sharing with you how we're surviving. In terms of nutrition, I would like to actually share a story. This is a meal that we eat on a daily basis. It's called irtab. I know the youth community is probably familiar with it. So it's prepared with bread, either fried or boiled potatoes. And when you hear this, and with ketchup, when you hear this, what do you hear? We hear, okay, bread is carbohydrates, and potato is carbohydrates, and basically we're consuming carbohydrates. Our balanced diet is only consists of this carbohydrate, and if there is something that needs to be done as well, it's banning this food from universities. We really need to stop eating it. And in regards to mental health and SRH, however, it is a really serious issue. The stress, the pressure, and societal expectations of these youths are really driving them into getting to drug consumption. I mean, alcohol consumption, and even they're doing this to only cope with their daily life. And so that there aren't people that are actually listening to them, saying, what's wrong, what's happening, just talk to me, just these kinds of communications and talks with them. So I think if I had the opportunity, I think I would do differently. If the problem is lack of education or awareness, these kinds of policies, I think they need to be integrated with the national curriculum. And I know that even university students don't even know that we're talking about sexual reproductive health. They're saying if we start talking about sexual reproductive health, they'll be like, we've never talked about it, we've never discussed it with our parents, we've never discussed it with our teachers. And so that if these policies are actually introduced to the curriculum, how many primary, secondary, even us university students are going to really advantage from this? And finally, I think we need to understand that when implementing policies, we need to understand that they need to be community based, and that we need to know what did we learn from our previous policies, and what things do we need to change. Even us as youths, you need to give us the policies, we need to read them, we need to understand what they're saying, and look for any gaps. And that is what I'm saying. Thank you so much.
It's amazing, and I've really learned a lot from you. We will continue this conversation. Perhaps maybe we can take one or two questions from the audience. You've heard about much of the progress that's happening, the state of adolescent health around the three pillars: nutrition, sexual reproductive health, and mental health. We've heard about the response by the countries in terms of policy environment and in terms of programs, challenges. Any questions? But you've also heard from Mariamawit on what and how does it translate from the point where youth and adolescents stand And I think that was an important contribution. So we can take one or two questions. Yes, I see one hand. Will there be another question before we close? I think there is one question here, right? Okay, please.
My name is Gertrude and I'm from Tanzania. Thank you very much to all the panelists who have spoken from nutrition, mental health, SRH, and the youth representative herself. My question is about how do we then bring all these together? Because, for example, in just a simple example is that when we talk about the first 1,000 days, the mother's nutrition at that particular moment is very important about the outcome of a child. And that will determine whether that child will survive or not. And that will determine whether this young mother will go into postpartum depression or not. And that's all of it. You cannot have them in 3 different places if we really want to see real change in the community. So maybe in a minute, just from all our panelists, the 3 panelists, how do you suggest that these 3 things can be put together, and how do you do that so far? And then maybe 2 minutes from the youth representative on then how will it be meaningful for the youth community? How can they bring all these together for it to have meaning to you as the key stakeholder and beneficiary? Thank you.
Okay, one last question, because that's already 2 questions. Okay, we'll take one more. I think I saw a hand. No, I think now those will be 2 questions from Tanzania. We should have a question from another country. Right.
Thank you so much. My name is Arthur Omondi, and my question is to the panelists and the experts in general. So I come from Nutrition International, and we do a lot of programs on adolescent nutrition. And really, this is an emerging field, adolescent health, even in terms of research. But then the challenge now becomes translating this research agenda into programs and policies. How can we ensure that this emerging field is really integrated into policies? For instance, from our experience, you will find that the traditional fields that have always had evidence are the ones that are prioritized in policy. For example, the first 1,000 days. And then there is enough evidence targeting adolescents. How do we then ensure that this emerging field is now integrated into policy, both at country level and even at the regional level? Because that has been one of the issues that we've encountered. Thank you.
Thank you so much. So maybe to the first question, and very briefly, maybe I'll request our first 2 panel members to respond to that, and then we will request Mariama to respond to the question that second part of the first question, and then the second question maybe I'll request we can respond, me and you.
Yeah.
So that we keep it on time. Yes, please.
Yeah, thank you. I think this is a tricky question, and I think it's the right question also. Thank you. I think for 3 domain need to work together. I think we need a good collaboration, or multi-sectoral coordination. And because, adolescent, the health sector could not only address, this issue. We need to bring other sector. For example, the education sector has to come on board. The social sector has to come on board. So in short, we need to have a very strong, accountable, multi-sectorial coordination platform, which is to certain ways accountability. This is, I think, the only ways which we can, 3 of this will work together. Yeah.
Thank you very much, and thank you for your question. I will use my life as an example, and I suspect it aligns with many of our experiences. Even though the fields of research or knowledge are compartmentalized, in life it doesn't work that way. When I was growing up, my parents were responsible for putting food on my table. They affirmed me mentally and built my mental, my sense of understanding of my potential, and helped me, cope with the normal stresses of life. And similarly, when it came to knowledge about sexual and reproductive health, my mother taught me when it was time to see my period, what to expect, how to protect my body, the family. Which is why I do believe that we need to go back to the drawing board. I honestly advocate for the strengthening of families, family support programs, social protection. For me, that's the basic. A lot of the literature tells us that when children exist and adolescents exist within safe and protective family structures, this, is a safety net in terms of access to good nutrition, in terms of, mental health, and understanding their potential, being able to cope with life and its issues, and understanding their role as, being productive citizens. It also helps them with their sexual and reproductive health. But, a mother who is not aware, and I wouldn't restrict this issue or understanding of awareness to just strictly formal education. There's ways that we can spread the literacy to these actors, these family actors, even if they haven't had the benefit of formal education. We do need to go back to family structures. When we see fragile family settings, we see a lot of, adolescent challenges, whether it's mental health, whether it's nutritional, challenges, whether it's sexual and reproductive health challenges. And many nations in Africa are experiencing a lot of stresses, especially economic stresses, that further, threaten family structures and family supportive systems. If family livelihoods disappear or family income, falls, then you're experiencing an uptick in child labor. It's clear, the evidence is clear. When, mothers are not present, then predators come in, they abuse your children, or sometimes, children don't have access to the right kind of information and they make poor choices in terms of sexual health. So my clear message with respect to your question is that if we want to prevent so that we're not remedial, a lot of what we're doing is we're trying to resolve, challenges that have reared up ugly heads because foundations were broken. I think Africa needs, and Sub-Saharan Africa and our policymakers have to go back to strengthening our families. There's too much fragility in family context, and that's where a lot of these ills penetrate for the children and adolescents. Thank you.
Sorry, can I?
Think
you
want to respond to the second part of the question?
Okay, thank you. I hope I don't go off topic, but I think your question was how do we integrate this, or how do we ensure that the adolescent get the right knowledge on nutrition, SRH, and mental health, right? So I think in order to have an effective and inclusive policy in regards to these topics, I think most of the presenters has also described this. We need to engage youths. I think that I can't stress this enough. I think youths need to be able to talk. They need to be able to, since they are the next generations, we need to, you need to equip us with the right skills, with the right knowledge, and with the right resources to better the nutrition knowledge, SRH, and mental health knowledge, and just as an advice, just to give guidance to the policymakers. I just said it earlier, but I'd like to repeat it because policies are for the communities. Policies are for adolescents, right? So I'm going to come back to what I said earlier. The policies should be should focus on the community only, communities, adolescents, and they should only target those people because they're the ones who are going to be using the policies and living by those rules. So I hope I've answered the question. I'm gonna give the mic to my fellow.
Thank you. Okay. Hello, can you hear me? Okay. So sorry, but just to add on to your first question. So I feel that getting SRH and nutrition and mental health together under one umbrella is possible. From a position that I'm coming from in Ghana, we have a policy called the RMNACH, which is Reproductive, Maternal, Newborn, Adolescent, and Nutrition Policy. It's a mouthful, but it speaks to what you are asking, which is we have the evidence of how interlinked some of these domains are. And we know that we need to tackle them in a very multifaceted way. The policy can be developed, but like I said, it's a policy on paper. It needs to be implemented. And a key thing to achieving that is the dissemination. There are policies that people in country do not know about. There are policies that adolescents in the country that the policy has been developed for are not aware of. And they are not aware of the services and what they have available to them because of that policy. So dissemination along the different segments of groups, policymakers, key stakeholders is very key. The next thing is training. Some of the policies are done, and the supply side of the policy, your clinicians, your health workers, those who will deliver the counseling, who to talk to when you're in uni and you want someone to speak to, need to be trained to be that face that they engage with. That's how you are able to overcome that. And you need to coordinate it. We've seen a lot of that lapse in many countries. The coordination across the different sectors to make sure that now you have all these under one umbrella. Now you have trained people to deliver this. Now you implement it and you monitor it. I think that's the best way to kind of take control of managing the three. Thank you.
Thank you very much. I think just to build up on that, the integrated policies, it reminds me of an example, and I think this has been used a lot in our discussions within UNICEF. And there is, to be extreme, a challenge to say, what's the point of doing everything in immunization and let the child die from malnutrition, or doing everything in immunization and nutrition and let the child die because of WASH, the unclean water, unsafe water. And I think this speaks the same. It mirrors the same for adolescent. What's the point of doing everything for adolescent in nutrition if you're not really going to improve their mental health, and then they will let them die with suicidal disorders or depression? Or what's the point of doing everything for mental health and nutrition and then not doing enough for sexual reproductive health, ultimately really not give them a chance to have? So I think this kind of summarizes what you have shared with us. Dr. Glema, any question from you?
Okay, I thank the panelists for the discussion we had so far. I want to forward one last question, or I want you to reflect on one final thoughts or key takeaway message from this panel. So 3 minutes for each, maybe for the sake of time management.
Even less. Should we start here?
So a take-home message. I think that we need to, like you said, rise to the challenges. The very positive feeling you get from everyone in this room is that we are very aware that there is still a lot to be done. Notwithstanding that a lot has been done, but we need to now find the gaps, the little gaps, the little cracks. In fact, there are no gaps anymore because we know so much, but there are few cracks that now need to be patched up. And I think that's one thing we need to be very open-minded about, and know that we still need to keep looking and still trying to improve on the system for adolescents everywhere. And these are the missing links. Yes, thank you.
Okay, thank you. My key takeaway from this panel is that all three, nutrition, SRH, and mental health, are really important, and they're almost as if they're interdependent. As Dr. Noor said, we can't really, how do you say it? In Amharic, you can't really separate them. Yeah, we can't really separate them, and that's if you don't have the right nutrition, you won't have the right mental state to even think about SRH. If you don't have the right to, the knowledge of how to handle stress, how to handle your mental health, you won't have time to think about sexual reproductive health or your nutrition, and it all goes more so for nutrition and mental health. But that is my key takeaway from this panel. Thank you.
Thank you very much. I think I will also re-echo Maria Mawitz. comment, earlier comment. One of the things I found very exciting about the AHA guidance document was the part about agency. And it snuck in there quietly, but it's so powerful, and it comes to what you said, that we have to hand over the power to the young people. In girls' education, one of the things we recognize is that we try to see girls as experts on their lives, and it's an interesting dynamics. And if we see young people as, critical, not just beneficiaries that we're speaking for, then even in the way we communicate the research findings, we make it digestible for them so that they can take that knowledge and become self-advocates, and it also improves their decision making around these issues. I think that if I were to go away with a last statement to all the actors here, I would say that something unique that should stand out of adolescent research, and the research community is the manner in which your findings are disseminated. It has to be adolescent-centric. It has to be different from how the typical traditional, research community disseminates its findings. I think that it's critical, and I'm so glad that she's in the room because it shows a sensitivity towards that. But going out, I think that it would be very okay if anytime, adolescent research was, accessed anywhere in the world, it appears different. The, manner in which it is put out is different. There is nothing wrong with that, and even though, we have traditional protocols to preserve in research, you could pioneer that kind of, paradigm shifting experience for young people. So let's, I would urge us to be adolescent centered in our approaches, from even collecting the information, seeing them as partners, to disseminating the information, seeing them as, critical voices in, self-advocating for their own rights. Thank you very much.
Thank you. I also echo what already said. As it has been said, we know much those problems which we mentioned, all of us, this morning, as well as maybe tomorrow as well. And we have also policies, strategies, including Ethiopia. So I think we need to read things on those policy strategy if adolescents are engaged. And we have to make sure that adolescents are part of that intervention. And we have to use also as advocacy like Maramawit, to support other adolescents, on delivering those messages. And of course, family is also important. That's, I think, very important. We need to engage and listen adolescents and make sure that on already existing or developed policy, they are part of that, and adolescents are aware, and make sure that they are also, part of the solution. Thank you.
Thank you, all the panelists and the conference participants for the very interesting discussion. Let us give them applause for the panelists. So we believe the diverse perspective shared here will be invaluable as we move forward, and it will be a good pillar for stimulating the discussion and the collaboration action we will have in the subsequent discussion sessions. Thank you very much. We end our roundtable discussion here.